Good morning. Today we will discuss about anti-cancer drugs. The first part of this has already been covered. This is the second part. Antimetabolites. Folate antagonist, that is methotrexate. It is the most commonly used anti-cancer drug. It is a CCS drug and acts during S phase of the life cycle. It is neoplastic, immunosuppressant and anti-inflammatory drug. It is a drug of choice for choriocarcinoma. It is used in acute leukemias, Burkitt's lymphoma and breast cancer. Low dose of methotrexate, that is 7.5 to 25 milligrams once weekly, is used for rheumatoid arthritis because it prevents joint erosion. It is also used in psoriasis, inflammatory bowel disease and organ transplantation. Methotrexate. It structurally resembles folic acid. It inhibits dihydrofolate reductase enzyme and prevents conversion of DHFA to THFA. It depletes intracellular THFA. THFA is necessary for synthesis of purines and thymidylate. Purines and thymidylate are necessary for DNA and RNA synthesis. The adverse effects of methotrexate, that is megaloblastic anemia, pancytopenia and hepatic fibrosis. What is folinic acid residue? If we see dihydrofolic acid, DHFA, it gets converted to tetrahydrofolic acid in our body with the help of an enzyme dihydrofolate reductase or DHFR. Now this tetrahydrofolic acid helps in the synthesis of purines and thymidylate, which helps in DNA and RNA synthesis. Now if we give methotrexate, it blocks the enzyme dihydrofolate reductase. So conversion of DHA to THFA is hampered. Now if we give folinic acid or leucovorin or citrovorin factor, this bypasses this part. So directly it is affecting the tetrahydrofolic acid and there is direct synthesis of purine and thymidylate. And ultimately it helps in DNA and RNA synthesis. To put it in text, methotrexate is dihydrofolate reductase antagonist. The toxic effects of methotrexate on normal cells can be reduced by giving folinic acid. After a few hours of methotrexate, leucovorin is given. Folinic acid is the active coenzyme form. It bypasses the block produced by methotrexate as we saw in the figure and rapidly reverses the toxicity. This method is called as leucovorin rescue or folinic acid rescue. High doses of methotrexate are possible due to the availability of folinic acid. We give high doses for a better neoplastic effect. Purine antagonists, 6-mercaptopurine. It is activated to its ribonucleotides which inhibit purine ring biosynthesis and nucleotide interconversion. It is a CCS drug and it acts in the S phase of cell cycle. It has immunosuppressant action. It is administered orally, has poor penetration through blood-brain barrier. It is used in acute lymphoblastic leukemia. The adverse effect is bone marrow depression. Purine antagonist, 6-mercaptopurine and 6-thioguanine. So normally if we have a good amount of 6-mercaptopurine, then it is helpful for its anti-cancer effect. What happens is 6-mercaptopurine gets converted to 6-thiouric acid. But there is a drug called allopurinol which inhibits the enzyme xanthine oxidase. This xanthine oxidase helps in the conversion of 6-mercaptopurine to 6-thiouric acid. So allopurin inhibits this enzyme xanthine oxidase. So we have more availability of 6-mercaptopurine. Allopurin interferes with the metabolism of 6-mercaptopurine by inhibiting the enzyme xanthine oxidase and increases the anti-neoplastic effect of 6-mercaptopurine. It is frequently used in cancer patients receiving chemotherapy to prevent hyperuricemia and reduce the dose of 6-mercaptopurine. Pyrimidine antagonist, 5-fluorouracil, it is getting converted to FDUMP, that is fluorodeoxyuridine monophosphate. Now this interferes with DNA synthesis and functions by inhibiting the enzyme thymidylate synthetase. So DUMP, which is getting converted to DTMP, here D is missing, that is deoxythymidine monophosphate, through which DNA synthesis occurs. So this is not happening because fluorouracil, which is converted to FDOMP, which is inhibiting this enzyme. This is not getting converted to this, so DNA synthesis does not happen. It is used in colorectal, upper GIT, breast and ovarian carcinomas. Plant products, vinca alkaloids. Vinblastine and vincristine are derived from periwinkle plant. They are CCS agents. They act during the M phase of cell cycle. Vinblastine and vincristine have same mechanism of action but differ in anti-tumor spectrum and toxicity. Vinblastine and vincristine, they bind to beta tubulin, that is the drug tubulin complex. This inhibits its polymerization into microtubules, so there is no intact mitotic spindle, and ultimately cell division is arrested in metaphase. Uses and adverse effects of vinca alkaloids. Uses of vinblastine, it is used in Hodgkin's disease, carcinoma breast and testicular tumors. Vincristine, it is used in childhood leukemias, childhood tumors namely Wilms tumor, neuroblastoma, and also it is used in Hodgkin's disease. The toxicity of vinblastine, it is bone marrow suppression, anorexia, nausea, vomiting and diarrhea. Toxicity of vincristine, peripheral neuritis with paresthesia, constipation. Vincristine has minimal myelosuppressive action also. Taxane. Paclitaxel is a taxane derived from bark of western yew tree. Docetaxel is a newer taxane administered by IV infusion. It is used in advanced breast, ovarian, lung, esophageal and bladder cancer. Adverse drug reactions are bone marrow suppression, peripheral neuropathy, myalgia and hypersensitivity reactions. If we see the mechanism of action, paclitaxel, it binds to beta tubulin and stabilizes the microtubules in the cell. There is formation of abnormal microtubules. This inhibits mitosis. Camptothecins. Topotecan and irinotecan are camptothecin analogues. Mechanism of action. Camptothecins bind to and stabilize DNA. Topoisomerase 1 complex inhibits the resealing function. Strand breaking action is not affected. Thus they produce cell death. They are used in advanced ovarian, lung and colorectal cancer. Adverse drug reactions include bone marrow suppression and GI disturbance. Epipodophylotoxins. They act in the S, G2 phases of cell cycle. Etoposide is used in testicular and lung cancer in combination with other cytotoxic drugs. It's also effective in non-Hodgkin's lymphoma and AIDS-related Kaposi's sarcoma. Adverse drug reactions include bone marrow suppression, GI side effects such as nausea, vomiting and diarrhea. Hepatotoxicity is seen with higher doses. If we see the mechanism of action, etoposide and teniposide, they form complex with DNA and topoisomerase 2. This is the drug DNA topoisomerase 2. They prevent resealing of broken DNA strands. Ultimately, this leads to cell death. Anti-cancer antibiotics. The mechanism of action, they have direct action on DNA. They bind to DNA through intercalation between adjoining nucleotide pairs on the same strand of DNA and block transcription of DNA. So this is with the drugs like dactinomycin, doxorubicin and daunorubicin. Bleomycin binds to DNA and produces free radicals which cause DNA damage. Actinomycin, it is administered intravenously and is used to treat Wilms tumor, Ewing sarcoma and choriocarcinoma. Adverse drug reactions are bone marrow suppression and gastrointestinal. Anti-cancer antibiotics like mitomycin C. They are converted to compound which acts as an alkylating agent. It is used to treat GI tumors, cervix and bladder cancer. Adverse drug reactions include bone marrow suppression, GI side effects and nephrotoxicity. Bleomycin, it is administered through subcutaneous, intramuscular and intravenous routes. It is used in the treatment of testicular and ovarian tumors and also in Hodgkin's lymphoma, the ABVP regimen. ADRs include hyperpigmentation of skin, pulmonary fibrosis, There is very little bone suppression because it spares the bone marrow. Anti-cancer antibiotics, doxorubicin and daunorubicin. Daunorubicin is used in acute leukemias. Doxorubicin is used in solid tumors. Adverse drug reactions, bone marrow suppression, GI disturbances, cardiomyopathy with congestive cardiac failure, hypotension or even arrhythmias. Mithramycin, it reduces serum calcium levels by inhibiting osteoclasts. It is used in the treatment of hypercalcemia with bone metastasis. Enzyme L-asparaginase. It is an enzyme isolated from bacteria E. coli. Asparagine is amino acid necessary for protein synthesis. Normal cells synthesize asparagine as they contain asparagine synthase enzyme. Cancer cells lack this enzyme and they depend on exogenous source like plasma. Toxicity of these drugs: hypersensitivity, hyperglycemia, headache, hemorrhage, pancreatitis. The mechanism of action of L-asparaginase. Asparagine is converted to aspartic acid with the help of enzyme L-asparaginase. L-asparaginase degrades asparagine in plasma to form aspartic acid. Hence, neoplastic cells are deprived of asparagine, resulting in cell death. It is used in the treatment of acute lymphoblastic leukemia. Miscellaneous agents. Hydroxyurea. It acts in the S phase of cell cycle. It is a CCS drug. Mechanism of action: it interferes with conversion of ribonucleotide to deoxyribonucleotide by inhibiting ribonucleoside diphosphate reductase. This results in inhibition of DNA synthesis. It is used in CML, polycythemia vera and psoriasis. Adverse drug reactions are bone marrow suppression, leukopenia, anemia and thrombocytopenia. The other miscellaneous agents include tyrosine kinase inhibitor imatinib, which is used in CML, angiogenesis inhibitor bevacizumab, which is a vascular endothelium growth factor inhibitor. It is used in renal cell cancer, lung cancer and breast cancer. The other drugs, that is epidermal growth factor receptor inhibitor, that is geftinib. It is used in non-small cell lung cancer. These are the references. Thank you very much.